My presentation here in the ACC this year is going to focus on selection criteria to heart transplantation. There is actually going to be a change in the selection criteria due to the new guidelines that was just published a few months ago. And part of the goal of this talk is also to present what are the changes and what are the challenges that we are facing in the era of heart transplantation today in 2016. First of all, there is multiple understanding right now that heart transplantation is a gold standard of therapy with patients with advanced heart failure is limited and the resources is scarce. And as such, we are usually doing 2,000 to 2,500 transplants a year. And we need to carefully select the patient that we choose for this heart transplantation. The changes that occur on the level of some of them of contraindication that were in the past that became indication, and indication that were in the past that now seems to be a little bit, we need to be more cautious and careful when we go into those transplantation. A classical example that is going to be discussed during my presentation is going to be patient with pulmonary vascular resistance. Today we know when we go to heart transplant alone, we try to do it to patients that have a better chance to survive the heart transplantation. And the new heart that is going to be implanted into them is not going to be challenged by surprise or that can be delivered due to elevated pulmonary pressure. Whenever we assess those kind of pulmonary pressure as part of the transplant evaluation, if a patient have a pulmonary vascular resistance that's in more than 3.5 or with transpulmonary gradients at more than 16, we usually say this patient at that time point is not a transplant candidate unless we will prove that we can reverse those pulmonary vascular resistance or transpulmonary gradient by using other medication that are going to reduce those pulmonary vascular resistance. As such, we are going to focus on what is currently the level of support that we allow to give patient before we say this is a fixed pulmonary hypertension and they should not go to heart transplantation alone. If the age permit, maybe they should get heart and lung transplantation combined. Or we should say those patients are not good transplant candidate and should get mechanical circulatory support as a therapy for their advanced heart failure. Another classical example that I'm very proud of in the change in the guidelines is actually our approach to patients that are HIV positive. Historically, HIV positive patients were contraindication for heart transplantation. And the reason was combined. One, the fear that the immunosuppression that we need to give post-heart transplantation will flare the virus and will create it from a carrier. The patient will move to an active AIDS disease. The second was the challenges by combining a lot of medication together, HART medication that is given for the HIV side by side by the immunosuppression that's given to the heart transplant patient. And three, more important, is actually the social connotation that sometimes is related to HIV positive patient. In this specific situation, me, myself, and my team invested a lot of time in our research to look at HIV positive patients and how they do after transplant, and we learned that actually they do good. So maybe the fear that we have is not so realistic, and it was more applicable to the 80s when there was no good medication for HIV. And now, when there is good medication for HIV, not to let them transplant is a problem. So one of the biggest changes in the new guidelines is that HIV positive patient is not a contraindication by itself if the patient have a viral load that is undetectable, a CD4 count that is more than 200. They take HART medication and prove to be with good compliance and without any other contraindication for transplant. Meaning, finally, there is equal access to care in the related to those patient population.